For Global Medical News Network, I'm Heidi Spleak, reporting from the annual Caribbean Dermatology Symposium in Rio Grande, Puerto Rico. How has the thinking changed about treating psoriasis at an earlier age?
Well, I think classically, and not so long ago, we used to think that we should kind of save our therapies for our patients until they really needed them. So we might think about methotrexate or cyclosporin in a 50-year-old because we were worried about how toxicity might accumulate. Two things have really changed since then. The first is we have a large armamentarium of medications that we can start that don't have those same types of cumulative risks. But the second, I think, is very clear evidence that treating patients early in their disease may have impact that affects the rest of their lives. It may affect what jobs they can do, it may affect their educational status, it may affect their socioeconomic status, and importantly, of course, it may affect their overall health as well. Common comorbidities we see with patients with psoriasis are, of course, obesity, hyperlipidemia, hypertension. We see increased alcohol use. We see distress, depression, and anxiety. If we can intervene in people's lives before these become irreversible, we may change a lot of things that happen later on in their course.
So what are the implications then for screening and treatment? What should dermatologists be doing right now?
Well, I think at the moment there's not a lot of evidence that we should do more than what are the recommended screenings. But the important thing to note is that many of our patients are underdiagnosed and not up to date on those screenings. So it's important when you start to establish a relationship with especially a moderate to severe patient who is likely at higher risk for many of these things, is to assess how good is their primary care, how can you better that relationship, and especially if you are not feeling comfortable taking on some of the other aspects of their care, making sure they're referred into someone who will. We need to make sure they're up to date on their screenings and that we can modify any modifiable risk factors in order to make sure that they don't develop increasing comorbidities and health problems later on. So especially for patients who are on systemic therapies, vaccinations are going to be critical because we do know that there is some level of increased infection whenever you have any immunosuppression. So the classic ones like flu, I think people really know about, and important that patients know they can only take the killed vaccine. I always tell them take the one that hurts because that's fairly memorable. The inhaled one is a no-no. I think the two that may get missed sometimes if you're not screening for them are HPV vaccines in especially young women and young men. For women, of course, we're trying to avoid cervical cancer, but we do see genital warts in men who are on TNF antagonism, for example, and so consequently you'd like to prevent that as well. Pneumococcal vaccine for patients over 65 is the recommendation, and again, I think isn't always followed up to date. Really important to make sure that patients who are on any type of immunomodulatory or suppressive therapy have that up to date.